Okay, I think we might just make a start, if that's okay, with everybody. Okay, so thanks very much everybody for joining the webinar this afternoon. The purpose really is to provide you with an update on the progress that we've been making since we last met, which was in December, on the development of the new management structures under the regional health areas. And we've made quite a bit of progress since then, so it's a good time for us to be talking. Over the course of the afternoon, we've got myself and we've got Mary Ward, who's IHA manager for Mayo, and we've got Pat Nash. Pat is the regional clinical director for the West and the Northwest. All three of us will be kind of presenting across a relatively small number of slides. And really our hope is that we'll be able to get through the presentation material fairly quickly and give plenty of time for questions and hopefully plenty of time for answers as well over the course of the meeting. My hope is that I'll just give you an overview, first of all, on the progress that we've made with a strong regional slant in it. Obviously, there's a context to all the changes that we're making, and it is that that the reforms that are taking place are taking place across the whole country. So it's not just within the West and the Northwest, but we also are cognizant of what's happening across the country as well. Actually, just before I go on any further, it might be helpful just for me to remind people if you could just go on mute, it'll just improve the sound quality for everybody. There's 580 people on, so it'll help if people can go on mute. Thank you. Mary will take us through the detail of the model that we're focusing on for the IHA level management team, and there's quite a bit of detail on that. So that'll take a little bit of time just to tease through, and then Pat will then take us through the networks of care. And really, it's important that you consider all of it together, because as a management structure, it works and it functions when all parts of it are in place and when all parts of it are functioning together. Okay, so one of the things I suppose that we did early on in this process, going back to I guess the middle of last year, was that we came up with a vision and a mission statement for our region. And while the vision statement to some extent is a bit of a statement of the obvious, this is what we see in vision statements, there are a couple of aspects to it that I think are particularly striking. And one of them is that there's a strong focus on the quality of the care that's being provided, and the second one is that it's about improving health and well-being of the people that we're looking after. In other words, our vision is not just about the provision of services; it is about improving the health and the well-being of the people that we're looking after in the West and the Northwest. The mission statement, and I'm bringing that to your attention as well, it's more detailed, of course it is. And I suppose woven in and out, what you'll find is the values of the HSE, the care, compassion, trust and learning. You'll find that in it. You'll also find quality of care is mentioned in it. And of course, the other element that's very strongly referenced in it is our own staff and the need to remember that we provide healthcare to people, but we do that through our own staff. So I had asked that they be included at the start of this process, just because the slides will be shared at the end. I'd maybe ask you to just give a little bit of thought to the vision and the mission yourselves in your own time. We have made a lot of progress, I guess, since the 11th of December when we last met. We focused very much on trying to, within the region, to come up with a clear picture of how we will implement the framework that was agreed at the National Steering Group for the management team level at IHA level. So just to remind you, we've got 4 integrated health areas in our region. We've got Donegal down as far as Ballyshannon, and then we've got South Donegal, Sligo, Leitrim, and a bit of West Cavan. We have Mayo standing on its own, and then we've Galway and Roscommon as an IHA area. So that's 4 IHA areas. And all of these, and the management structure that Mary will be describing to you in detail later on, refers to all 4 of them. It's taken a bit of effort, I suppose, to try and work through all of the detail of how that will work. We're not starting from a greenfield situation. We are trying to design a management structure in the context of us continuing to deliver care every single day of the year and on a 24-hour basis. So there's no opportunity to stop and to reset and then restart. It is a question of trying to design and develop this new structure while we continue to deliver care, as everybody understands we must do. And similarly, I suppose, we are starting from a position of having a defined region and also defined number of hospitals, defined number of services in the community, and so on. And we're trying to make sure that our structure that we put together supports the delivery of the mission and the vision, but also is practical, that it makes sense in the context of the region that we're serving, the population that we're serving. All of that work came to, I suppose, came to a head or came to a conclusion to some extent at a very important workshop that we held in Sligo around the middle of February, which was focused on describing what the model might look like then to our heads of service, general managers, clinical directors, and management team across the region. And it was developed on the basis of we had arrived at the conclusions and the decisions that we've arrived at on the basis of engagement with all of these people over the course of January, some of December, and into early February as well. So it was an important meeting, and it's probably it teed us up then for further engagement at national level, both with unions and with other stakeholders, including the regulators. And finally, it was endorsed at the steering group meeting on the 19th of February, which brings us more or less to today. It allows us to present at this webinar here today. I might just move on to the next slide, Caroline, if that's okay. And really, I suppose when we met the last time, I was talking about the interim period, and we were referring to a period that commenced at the beginning of October and ran straight through to the 3rd of March. And the purpose of that period was to allow the services within the regions to continue to function while we were doing this design work and while we were working towards it. It was necessary to create that kind of window just to give us that breathing space so that we could make sure that we had given enough time and consideration to what the new structures would look like. So the regional management team has been in place, and we put together our own oversight team that was jointly chaired by Pat Nash and Mary, both of whom are presenting here this afternoon, and set up a number of work streams that allowed us to design what our structure would look like and to put I suppose, a formalized shape on our approach to implementing it as well.
No, that's
just a reminder for everybody to go on mute, if that's okay, please. Thanks, Sean. I might ask you to unmute. Yeah, thanks, great. And I suppose what it does is it brings us. I mean, today we're the 3rd of March, so we're at the end of that interim period, and we have now commenced what we're terming the implementation period. So the implementation period is commencing today, the 3rd of March, and it's likely to run for about 6 months. It may be shorter than that if we can do all that we have to do within that time frame. Our commitment is that it will be done and dusted within the 6 months, and not just that it'll be done in this region, but it'll be done across the country as we all have to move together on this. And so finally then, the focus in all that we've designed has been on these 4 key design principles, and none of this should be a surprise for you because it has remained constant throughout all of last year. We have been, I mean, the purpose of the region is to remain population focused. We have been pushed very hard to ensure that we develop a very flat management structure, that we design a structure that supports the delivery of care and that it's sensible and that it's logical, but it doesn't add layers for the sake of it. In fact, every layer of management has to be retained within the model. It very much does focus on the networks of care, and you'll see that as we progress through the presentation here this afternoon, and the importance of networks of care, particularly around the quality and patient safety standards. And it also focuses on the principle of ensuring that we provide services in the most appropriate settings and at the lowest level of complexity that's possible or that's relevant to the needs of the patient at that time. So that brings us to the point, I think now, maybe of me handing over to Mary, so Mary can start to describe the model based on the Mayo example. Mary?
Thank you, Tony. So this example is of Mayo, but there's a similar example for each of the 3 remaining IHAs across the West Northwest, and they're all based on the same principle. While there may be some variation between IHAs, this flat structure is what will be replicated across all IHAs. So you'll see at the top is Tony, the Regional Executive Officer, and the IHA Manager reports directly into Tony. The IHA Manager will have a defined portfolio across the region, so they will have a specialist lead in one particular area, an area that's common across all of the IHAs. Underneath our reporting into the IHA manager will be general managers, and the general managers will be responsible for what we're calling community health areas. And within those community health areas will be the majority of services and the delivery of the majority of services, and they're reflected in the pink box. Those CHAs are based on approximately a population of 50,000. Some areas, some CHAs will have more than 50,000, others will have less, but in general, it's a population that we serve of 50,000. We expect the majority of service to be delivered at a CHA, and they include our current structures such as community healthcare networks, children's disability teams, home support. Sorry, just a reminder for everybody to go on mute, please. Home support services and our community mental health teams. Again, the majority of services that can be delivered nearest to the patient and the decision made nearest the patient. You'll see under the purple boxes, there are heads of service, and those heads of service will have responsibility for a portfolio depending on the care group that they're taking a lead on. They will have overall responsibility for regulated services that may be disability, older people, or mental health services. They will also have accountability for specialist services that go across a number of CHAs and that are county-based. So, for example, community specialist teams such as ICPOP or the Enhanced Community Care Programme for chronic disease. They will also have a defined accountability for an IHA, for services that go across an IHA. For example, they may take a lead for social inclusion or other services that are common across the 4 IHAs. The head of service will also take a lead in the networks of care, and Tony has reference networks of care. Pat will give more detail on these, but networks of care will span across all services that we deliver both in the community and the hospital, and they will provide a standardized approach to quality and patient safety. Also reporting into the IHA managers, there will be hospital managers, and there will be specific enabling functions such as QSSI, HR, finance. We'll also be looking to have a patient representative on the management team and a representative of public health. The management team will be made up of many different people. Some will report directly to the IHA manager and some will not, but they will have a specific purpose and function on the management team. So we might go to the next slide, Caroline. In order to move to the next phase, which is the implementation of the structures, we recognise that we need to do a change impact assessment. A change impact assessment will be a comprehensive assessment identifying the impact of the new IHA structures on governance, service continuity, support functions and people. It will prioritise the change management transition, and it will also identify the risks and the mitigation against those risks as a result of the implementation of the new structures. It will be led by the West Northwest Health Regional Implementation Group with input from the IHA managers, from service-specific experts, HR and other enabling functions. It will be done in a phased approach with 2 parts. The first part will focus on care groups across the region and identifying the change impact of the structures on each care group. And it will commence in March, April. Next slide, Caroline. This is just an example of the process around the change impact assessment. So we'll start with a number of workshops. both a preparation workshop, but also that will move on then to care group workshops. And those care groups will be care groups across the region that will come together with an IHA manager to identify the changes, the impacts of those changes, and to from that we'll identify the risks associated with those changes, and they will populate a risk register. The outcome of the workshops will be consolidated and validated, and we will then, from that information, provide a detailed transition plan and risk register in order that we can move ahead to the next phase and the implementation of the structures. Next slide. So I'm going to hand over to Pat, who will speak to the networks of care.
Yeah, I suppose the idea behind networks of care comes from the initial national model, and it's based very much around the idea similar to what we had in the hospital group of MCANs, or managed clinical academic networks. So it's a clinical governance framework or a care governance framework where you're looking for with disability, focusing on setting the strategy for the relevant area, and so providing oversight in the quality and safety of the relevant services, and helping in providing the assurance to us and the regional management team, and to provide leadership in these areas. In the hospital group, we've had 6 networks, women's and infants, or women's and children's cancer, perioperative medicine, and we've had lab and radiology separate here. They're combined, and that's something that is still ongoing discussion. And one of the things that has come back strongly is, as we move out to integrate those existing networks to expand them into the community, that there's a strong need for a children's network of care across the community, linked with a hospital. And then I suppose the newer networks are the ones that would be considered more predominantly community-based, mental health, older people, disability. So that and I suppose we would look on them as looking into the hospital and pulling out, rather the others looking out from the hospital out to the community. So I suppose that you're approaching these networks from different perspectives of the existing ones that are hospital-based, looking out into how you expand it across in an integrated fashion, and the more predominantly community-based of disability, mental health, and older people, which really crosses the spectrum. And I think the purpose of these is really, if you take older people, to try and set a pathway of care for older people that crosses the continuum from acute hospitals to the community, and breaks down some of the traditional kind of silos and pillars of care that end up from the pathway being quite difficult and disjointed for the patient. So the structure will be based around having a regional team, but a networked approach where you'd have a lead in each IHA who are part of the IHA management team, but would have a broken line up to the region, similar to the way we currently have ACDs, or associate clinical directors, at a site level, part of the site management team in the hospital, with a broken line up to the regional structures. Go ahead there. I suppose just to finish, that's a multidisciplinary team. It's not just a medical team, medics, nursing, HSEP, a GP representation. So it's a multidisciplinary team, not just a medically narrow focus team. The Gantt chart here looks at the overall implementation, and it's broken into 3 big phases. The design phase, which has come to an end, we're now in the start of March. Designing the structures, the high-level structures, as Mary's outlined, about the community health areas, the high-level integrated health area governance, along with the preliminary work and the networks of care. And you can see that then over the next 6 months, we're looking at 2 implementation phases. The first phase up to the start of June, and the second phase beyond that. And I suppose the key as we move into the implementation phase 1 is that the interim current governance structures arrangements remain in place. There has been no change from Friday to today, and and any change will be flagged well in advance, but the continuing structures persist as we plan the transition into the IHA CHA model. During this implementation phase and in the early stages of it, you can see there during March and April, we'll be doing the initial phase 1 and then a more detailed change impact assessments. And we'll be stepping up some of the regional structures, the regional structures around HR, finance, health and wellbeing, quality and patient safety. And we'll begin moving on to the more detailed implementation at an IHA level, stepping up for local IHA implementation teams. And I suppose that any and all change will continue to communicate as we have been, and the communication plan outlines right across this. Hopefully by June we'll be in the position to start fully implementing the IHA structure. There'll be ongoing engagement, in particular as people. This is a major change for people, and we realize and we'll be respecting the HR processes, the people and the change processes, and that we'll be working with nationally agreed processes and how we implement skill matching, skill development, implementation of the regional and the deployment to staff into the regional structures as we progress. But I suppose the main thing from this is just the three big we've moved from the design phase into the early implementation phase, doing the change impact assessment and beginning the initial implementation as we move in June into the full implementation of the IHA CHA structures. Thanks, Tony. And this is just some key upcoming dates, actually, that GP engagement actually is happening this Wednesday, the 5th March, not last Wednesday. And that I suppose we are also looking, in particular, the group, the HSEPs as a group, bringing them together to discuss and try and get structures along with structures in place, how we communicate with and engage with and put structures that will interface both at the IHA, CHA level, but also at the networks of care level.
Very good. Thanks, Pat. Thanks. So we're going to move into the questions and answers, and invite people maybe just to put their questions into the chat, and we'll take them up then from there. Just a couple of important points then to re-emphasize for you. One of them is that the interim phase that we described from the 1st of October to the 3rd of March, that comes to an end today, and so we're progressing now on to the implementation phase. The implementation phase itself, the outer limits of it will be that it will be 6 months, and if we can progress within that time frame sooner than 6 months, we certainly will. And I think the really important point that Pat makes in respect to that then is that that the current management arrangements that were in place on Friday last, they haven't changed today, so they haven't, and we people will be properly informed and consulted with and so on in advance of that happening. So it'll be well flagged to people when there's a change and a shift in the management structure within that time frame. Okay, so
I might start questions to you, Tony, if that's okay, and you can direct them then on if that's okay.
Thanks,
so we have a question here now on why is the health and wellbeing work stream starting a month later than the other work streams?
Pat or Mary, do you want to take that?
Take that if you want. I think we just were. I suppose we want to take it in feasible chunks, and that there's a lot of work being done nationally on the HR and the finance, and so those already are in progress. And from ensuring absolute clarity about quality and safety, we've been asked to prioritise that. So the health and wellbeing will follow on quickly. There isn't a significant delay, but we're taking it in bite-sized chunks as we go forward.
Can you discuss further the concept of the CHAs and how they will align with the already established CHNs? I believe CHNs are also based on a population of 50,000, similar to the proposed CHA structure.
I might have a go at that, and Pat, or Mary, you correct me if I get this wrong. So if we start with the region, and the region comprises the 6 counties with a little bit of West Cavans, we've divided that down into 4 integrated health areas, and I described those earlier on. Each of the integrated health areas is divided further into CHNs, Christina, as they were described, but we've used the term CHA, and the reason we've done that, it is the same thing, but the reason we're using CHA rather than CHN is because there's a logical continuity. You've got the region, you've got the IHA, and then you've got the CHA, which describes the smallest geographical split.
Okay, thank you. Where do dental services sit into this structure?
So I can take that one, Tony. So at the moment, there are dental services delivered across primary care centres across the West and Northwest. They'll continue to be delivered in those centres. There's one principal dental surgeon per specific geographic region, and that principal dental surgeon most likely will report into the head of service, as they currently do.
Can you advise on how the community finance, for example, the head of finance teams in CHO1 will be affected?
So I'll have a go at that one, Soil, because it's actually a little bit trickier. It's not than in some other areas. So CHO1 right now goes across 2 regions. So it's in Dublin and the Northeast, and it's also and Donegal and Sligo and West Cavan, Leitrim are in the West and Northwest. So we are working through a process then of how the resources that are currently allocated to CHO1 will be split across that boundary, and that's one of the pieces of work that will have to be completed over the course of this implementation phase. So we're not that far down along that track yet, but what I would say is that a reasonable logic will be applied to it. That we wouldn't expect that people who are currently based in, just for argument's sake, in Donegal, I wouldn't expect we'd be asking those people to up sticks and move over to work out of Cavan. So we'll be applying a practical approach to it. But in doing that, we have to be conscious that that the current arrangement is for CHO1. Resources are split across the boundary currently, and we have to do that sensibly so that both areas are supported afterwards.
Is there a plan for pharmacy integration similar to the HSCP piece?
I think definitely it's something we would be looking at. Again, it's I suppose any and all, we want to have an integrated and have a regional structures that support and enable the service delivery. So anything that is of benefit and that will help is definitely something that we look at.
And where will the safeguarding and protection teams sit in this structure?
So currently the safeguarding teams in the western part of the group report into QSSI. I'm not sure about the northern part of the group, but the structures will remain as is for the moment until we complete the change impact assessment and map out those services that go across a number of IHAs.
And from the Gantt chart, what is meant by recruitment reassignment?
So I'm going to go with this. So it refers to how posts or roles under the new structure are going to be filled. And I think it goes back to something that Pat said, but also something that I said. We're not starting from a greenfield site. We have people already working within the service who will become part of this new structure. The process through which people are assigned to roles will vary. It'll be different for different people depending on their circumstances. There are people who are in permanent contracts, and there are vacant posts, and there are people who are in temporary contracts, and there has to be a reasonable and a fair process applied to that. What we're currently doing is working through with all of the unions really, but probably the principal union really here will probably be Forsa and SIP2 and maybe one or two others, but we're working through a process through which posts and roles will be filled. And we'll agree that with them upfront at national level, so there's fairness across the country, and apply it then after that.
Is there any information about additional staffing or resources that will be made available to support teams to provide services?
One of the basic principles that we're working on is that the new management structure itself has to be delivered on the basis of existing resources. So it won't be that we've come up with a management structure that we will be saying or turning around and saying, well, if we had a couple more general managers or a couple more heads of service or whatever it be, it'd be perfect. That will not apply in this case. We must put together the new management structure on the basis of existing levels of staff. But I think this question that came in from Anne, I think it's probably broader than that, and it does relate to service provision. And in that context, there are a number of new posts that will come into the West and the Northwest as part of the service plan for 2025 to help enhance service in a number of areas in community, but also in hospitals as well. And we would expect that there will be further additional resources for 2026, and we'll be starting the process of trying to bid for those resources in the next few months.
And will CAM sit under mental health or children's services?
So it's envisaged that CAMS will remain under mental health services. However, should we and when we develop a children's network of care, it will have responsibility for bringing all children's services together, the children's services that are delivered by CAMS, that are delivered by disability, but are also delivered by primary care. So it'll be bringing all those services together in the best interests of the child.
And this one sort of links into that one, Mary. The next question was, what network of care do patients aged between 18 and 64 years without a mental health or disability diagnosis fall into?
Well, I suppose in the hospital they fall into either the medical perioperative cancer, the relevant. But you're talking about people who are in the community attending primary care services. I mean, they won't strictly fall in under a network, and we'll need to look, and I suppose work with primary care and see how we align any of their needs and how we put a network to a process in place to ensure standardization of the care provided to them.
And Tony, how will regional posts align with the structures?
So I'm interpreting the question really as a post maybe that's aligned with CHO2, for example, or a post that's aligned currently across CHO1, and how will that fit? So again, we'll have to look at how that would work across 4 IHAs and across one larger region now. And I can't imagine that it'll be the exact same fit for all different posts. Will have different demands and different requirements. But I do think it's important that we start looking more in the context of the region as being the 6 counties with West Cavan as well as part of that. And then and below that, thinking of it in terms of IHAs and moving away from the concept of the 3 county region of Galway and Roscommon, or Donegal, Sligo, Leitrim.
And is there an engagement planned with all staff, or is it just the HSE piece?
So that engagement with health and social care professionals starts with the health and social care professional managers in order that we can establish a communication pathway with all of the staff that report in to those managers. Equally, we'll be doing similar with others managers across the service as we develop the work streams.
And can you advise on HSCP managers will remain close to the service user journey and clinical service provision within the community healthcare areas, given that they hold the clinical assurance and governance responsibilities?
And again, that's not envisaged to change. There are health and social care professional managers that are across a number of CHAs, and that will remain. Their reporting line will support a number of all of the professionals that they clinically supervise and provide support to within their geographic region.
Mayo CAMS currently reports through Galway. Will this change to Mayo going forward?
It's not envisaged that will change for the moment. It's envisaged that it will remain as the current regional structure within the old region.
And when do you anticipate that recruitment campaigns will commence to fill temporary head of service and GM roles?
So I mentioned earlier on that we are putting together a framework for that piece about recruitment or filling of posts or whatever. So that will have to be completed in the next couple of weeks, because we've been further engagement with unions in the after St. Patrick's Day, the middle of March, and we have to bring a proposal to that discussion. Assuming we get agreement at that, we will be rolling forward then with the recruitment and the filling of posts as quickly as possible after that. We have a number of people who are in temporary posts at head of service grade and general manager grade within this region and indeed across the country. And as part of the last agreement that we had with Forza, those people were extended out to the 3rd of March. Not in every case, but in many cases, they were extended out to the 3rd of March. And of course, today we're on the 3rd of March. So we are extending contracts again to allow for the recruitment to take place in most cases. But I would expect that after that, that 3rd week of March, that hopefully we'll have agreement and that we'll be progressing them early in April with the recruitment.
Okay. And where do the national clinical programmes fit into these governance structures? How do we ensure that the clinical evidence-based standards are maintained and it doesn't just become operational? It's very important that clinical input is not lost, and this is a real danger. The example given is the CST ICPOC teams are currently in access and integration stream, but it's not clear where they live going forward. And clinical governance is a real issue for clinicians working on these teams, as well as ensuring clinical standards are maintained and patient safety.
I might take that, Tony. Well, I think the clinical programs are advisory. They set the models of care which we in the regions are mandated to implement and work with them. And I think we will be ensuring that there is clinical governance structures put across everything. So, so I don't think there will be ICPOP teams without are currently in access and integration stream. I see ICPOP as sitting under an older people's network from a clinical governance perspective. And I think we will be ensuring that all clinical care is under some network of care from a clinical governance and assurance perspective, and that it is based along national agreed models of care.
Okay. And where do therapy managers fit in the new structure? Many of them currently cover primary care, disability and older person services.
And it's envisaged that they will continue to do that. I suppose the change impact assessment will demonstrate to us, where those specific roles and responsibilities lie and how we map them into the new structure. And that will be done with the people who are expert in those areas. And as we referenced previously, that will be done per care group initially.
Do you know where palliative care will sit as a specialist service?
So I suppose palliative care in the community would be a mix between our Section 38 partners and direct HSE delivery. Again, we'll be looking at this in our change impact assessment. There will be a head of service with a responsibility for Section 38 organisations and service arrangements, and also with a lead in specialist services such as palliative care. But this will be mapped out in our change impact assessment.
And I suppose in the hospital, currently palliative care services sit under the cancer network. We realise it's not all cancer care, but we felt it best sitting there. So from a clinical governance perspective, that's where I'd see it in the future.
Okay. Is there any clarity at this point in regard to geographical areas staff will cover if they currently work within a service area, for example, mental health, and cover a CHO area when the services divide into IHA areas? The geographical spread is an issue, and also programmes funded for particular geographical areas.
So absolutely, geography is definitely an issue. So there's no doubt about that across the whole region, for sure. But I think this is probably a bit more specific than that. If somebody's currently assigned at a whole CHO level, maybe across Galway, Mayo, and Roscommon, how will that sit when we have two IHAs then covering that area? I think it's very difficult to say without knowing the service, to be honest, but we'll work that through. Again, what I would say though is that in general, not in every case, but in general, we will be trying to align our services against the IHAs, against the structures that are there, rather than continuing with the old Galway and Roscommon kind of division. Now, as I say, it's not every service, but almost all services will be divided across IHA boundary lines.
And what will happen to staff on specific purpose temporary hire appointments in this reorganisation? Will only existing permanent staff be considered for posts in the change process?
Well, it's easy to answer the last question first, and the answer to that is no. It won't only be permanent staff that are considered for posts in this change process. It will be people that are currently on temporary. There will be opportunities for people that are on temporary contracts as well to to put their names forward, and in some cases to compete for roles. In other cases, there may be other arrangements to be put in place. But I'm conscious that there are a number of people, particularly at general manager and head of service grade, that that are on temporary contracts, and that we have extended those contracts, trying to figure out what the management structure will look like, so that when we have that done, that we will be inviting people then to express interest or to move forward into these new roles. So I suppose the simple answer to give you is that I would expect that there will be opportunities in this for people who are on permanent contracts for sure, and for people who are on temporary contracts as well within our system.
What would be the reporting relationship for staff that work across IHA areas? For example, staff that work with CDNTS in current CHO area, 2 area.
So at the moment, staff that work exclusively in a CDNT would come under the CHA, which reports into a general manager. That's not to say the CDNT will report directly into the general manager. That will be more defined when we do the care group mapping exercise, and that will also identify staff that work across the region or across IHAs and where they're best placed to sit.
Okay. Can you confirm where community hospitals sit?
Not just yet, because one of the things that we have asked for consideration to be given to is the idea or the possibility that the district hospitals, for example, the 3 district hospitals in County Mayo, that the management of Mayo University Hospital may have some responsibility for them. Now, it's a good idea in some respects, because it helps to create a link between the hospital, the Mayo University Hospital, and the district hospitals, and that's useful in terms of patient discharge for sure. But it may not be a practical suggestion, even in terms of workload and so on. It may not just be practical. So what we've asked is that over the course of the remainder of this year, that be given consideration with all of the relevant stakeholders, the staff that are directly involved in that, and that we answer that question for ourselves by the end of this year. I've also asked that Galway would look similarly at the district hospital in Clifton to see if that's a practical consideration, or if it actually would make a real difference in terms of patients and patient care. If it doesn't, there's really no point in doing it at all. But I do think intuitively there might be something there, and so it's worth exploring. And so the straight answer to your question is that not yet. We can't confirm yet. But I mean, we certainly know where they sit today, and we don't expect that to change until we decide to make that change. But that is something we're considering.
Okay, and another one for you, Tony. Will there be a coordinated approach to the separation out of Cavan and Monaghan from West Northwest and Dublin Northeast perspective, noting the different stages of reconfiguration that the 2 areas are at?
Absolutely, and I think, to be fair, what I would say on this one is that I was very anxious that we continue to drive forward with the reforms within our own region over the last 5 months, just during this interim period, regardless of what pace other regions were moving at. But it's absolutely clear, and it has been made clear to me by our own staff, that it's not practical for us to suggest that we can proceed at a different rate or a different pace to Dublin and the North East, because there are staff that are currently responsible for services across that divide currently. So whenever we decide that we're moving forward, it must be 100% coordinated with what's happening in Cavan and Monaghan, and that we do it at the same time and at the same pace.
The next one's almost a request, I suppose. Can some kind of digital template be devised to support staff on various teams to determine objectives and put it in a review process to monitor success, or indeed any issues that may arise? This may impact on performance achievement processes in the future. Something to consider. I'll move on to the next question. How do you envisage the public health nurse service will work with the, and I don't know what the D there stands for, so I'll just
Director
of Public Health Nursing reporting to the head of service, but service has been delivered operationally at a network area.
So again, the whole flat structure is very much about working relationships and developing working relationships, while the general manager and the head of service both report into the IHA manager. They will have working relationships, and they will be working very closely together. The public health nursing service is delivered currently and aligned currently to community healthcare networks, with assistant directors being aligned or currently aligned to those networks, with one director of public health nursing across a number of community health areas. So it's envisaged that will remain. and the Director of Public Health Nursing will still have responsibility for her public health nursing service across the number of CHAs. However, she may be reporting in to the head of service, but there will be a matrix in relation to the reporting relationships. So I see the next question is pretty similar, Caroline. Yeah. So I suppose people need to bear in mind that we're actually moving away from care groups. And while you'll note in the IHA structure, that the Mayo structure, it has heads of service with responsibility for the regulatory services in mental health and older people and disability, or it's for Section 38 or 39 organisations. So while a Director of Public Health Nursing may report into a head of service, it's not going to be a head of service for older people or a head of service for disability or a head of service for mental health. They will have a generic brief across a range of services. They won't be sitting under older people services. They will be sitting under a head of service, or whatever that title of that person will be once that's decided through the HR processes.
Okay. And there was a second point to that question, which was, when will vacant frontline nursing positions be filled? These have been vacant since retirements, resignations from last year. Frontline nursing staff are under significant pressure to provide service to complex patients in the community.
Yeah, I might have go with that one, Caroline. So, yeah, I mean, for sure, I know that that our staff working in the community are working flat out and are under growing pressure because the numbers of patients that are receiving care is growing, as well as the complexity of the care that they're receiving. So posts that became vacant through retirements or resignations in 2024 should be fairly straightforward, and the people should apply for replacements through their existing line management structure, which will come up to the IHA manager, and then eventually all posts, believe it or not, they come as far as myself for final sign off. But we've done reasonably well over the course of the last, I'm going to say, 9 to 10 months or thereabouts, in getting posts through fairly quickly, getting them through the approval process. The recruitment process is taking us a bit longer, and for some grades of staff, it's been particularly difficult just to fill posts, to attract staff into those posts. But posts that became vacant prior to 2024, in fairness, are caught up in the pay number strategy and unlikely to be filled at this stage.
Okay. And this goes back to, so we've covered this a bit already, but can you speak further on how children's services might fit into networks of care and how this would interact with mental health networks of care?
I think the purpose of a network of care is to set the standards and oversee the quality and safety. And I suppose one of the key things that has been highlighted is that with children's services in separate kind of pillars of care in the traditional disability, mental health, primary care, a child may need to access any or all parts of that. And so that's the purpose of putting it under the operational governance at a community health area, that we should be focused on the needs of the individual and how we can provide it in an integrated fashion. So I look at the Children's Network of Care as setting the standards and the processes and how that is delivered and operated at a CHA level and up to an IHA level.
Okay. Will the regional disability lead posts commence imminently or in September of 25?
So there's two things I'd say about that. It won't be imminently, because the process through which the regional disability posts across the country are filled still has to be agreed with with Forsa in this case. So we have a meeting with Forsa, as I say, just after the middle of the month in March, and hopefully we'll progress a proposal with them at that point. Then the filling of the posts will proceed after that. So again, that'll be an early April timeframe, assuming all goes well in those discussions with Forsa, and then the usual timeframes within which posts are filled. And again, I think referring back to the question that was asked to me earlier on, I think this is a case where there'll have to be a coordinated approach, not just across the West and Northwest and Dublin and Northeast, but across the country, because these posts should all really be filled at the same time. And in conjunction with 3 national disability posts as well. So my best read on this is that it's going to be closer to September than it will be to March.
Okay. And I know you've covered this already, Tony, but just when will we know if permanent posts vacated in 24-25 will be approved for replacement?
Yeah, so in addition to what I said earlier on, the only other thing I'd say is that we Within the sales hospital group, we've had an IT system or an IT solution, might be the employment control, which helps us manage employment control. And we're now in the process of extending that out into the community across the region, and it'll be more efficient. It'll mean that people who, if you apply to have a post replaced, that it'll be done online, and you will be notified once the approval goes through, and there will be approval at different layers and all the rest of it in different levels, and you'll be notified automatically once that approval goes through. So at least people have better clarity and better transparency of what has been approved and where things are at within the system. So training has been rolled out right now on that system. So I would expect that to be available within the community probably during the months of April and May. And Maria, correct me if I've gotten that wrong now, but around that time frame anyway. And the only thing in general I would say is that posts that have become vacant in 2024 and 2025, in almost all cases, we're approving those for replacement.
And has a decision been finalised regarding the implementation and integration of new structures for the health regions and the impact this will have on the reporting structures of central services and staff that report nationally? If a decision is awaited, is there a timeline, please?
I don't think there's really a decision awaited. There are a few things that are happening. One of them is that there is a process in place to try to decentralize some posts from the centre out into the regions, identifying those posts and possibly identifying people that may wish to volunteer to be part of that process. That's still ongoing and will take some time yet. It is hoped that would also reach a conclusion, or at least substantial conclusion, within the 6-month period of this implementation phase. But other than that, the region will have a working relationship with central HSE in a number of different ways, but it will be different to how things have been in the past.
Okay. And Pat, this is back to you just for the health and wellbeing work stream. At the time during your answer, you mentioned HR and finance and the response. Surely these impact on the other work streams too.
Yeah, I mean, we have to take it in a stage fashion so the health, and there has been a lot of work done nationally from the HR and finance, and that's why they have been pivoted slightly a month ahead of starting the health and wellbeing piece of work. Just we can't do everything at the one time. So in our Gantt chart, the HR finance is due to start in March and continue along with the QSSI and QPS, with the health and wellbeing due to start in April. So there's not a significant delay, but it's just allowing us and the PMO offices and the support structures to be enabled they can't do every work stream in one go. So it's trying to do it in a coherent fashion.
And has thought been given to where contract management support units, CMSU, will sit in the new structure? How service arrangements will be managed and merged in the region?
So yes, definitely a lot of thought has been given to it, but I don't think there's been any final conclusions or decisions, just nailing it down and saying this is where it's going to sit, that's it, end of story. There are a couple of things that are a couple of basic principles that are very important to me in terms of how the new structures will work. So while we will have a contract management support unit, for sure, there's no doubt about that. My view is that the contract between the Section 39s and Section 38s, that they'll be managed at IHA level. So I'd be saying to Mary Ward as IHA manager for Mayo that, for this, the significant Section 39 organisation that's in her county, that she is responsible for maintaining and developing that working relationship and ensuring that the standards are being met and services are being delivered and so on and so forth. So that basis for the relationship has to be between the IHA manager with support from CMSU and indeed from others as well. But where they'll finally sit, Denise, just bear with us for a little while yet, and we'll work that through.
Okay. And then in terms of incident management, who will be the senior accountable officers? How many senior management teams will be supported by QPS, and how many senior incident management teams will be required to manage and supervise the incident management process? Will QPS and the community and acutes continue to operate separately?
I might take those. I think starting at the bottom, yes. No, they won't continue to operate separately. That they'll be integrated, and that's the whole purpose. Then that's part of the work stream is looking at QPS, QSSI, that it'll be aligned by the IHA area, which is an integrated governance for community and and the hospital. The senior accountable officers remain as they are. It's the IHA manager, the senior accountable officer within an IHA, within a hospital site, etc. So that's not going to change from an incident management structure, and I think we need to work and see how we put a framework around the incident management structure, building on what we have both in the hospitals and in the community, and that's part of the QSSI QPS work stream, and that there will be many of these things are for agreement and see how we do it. But the one thing is we want to be absolutely sure about the clarity around incident management and the quality and safety structures going forward.
Okay, I'll maybe link in with her.
Could I just ask anyone who's not speaking to go on mute, please?
Because it sounds like it's just a house and it's going to need home help.
Caroline, you're on mute now.
So somebody muted me for it. Who will the HSCP managers and the directors of public health nursing report into?
So because both the Director of Public Health Nursing and the Health Social Care Professional Managers cover a number of CHAs, it's envisaged that they will report into a head of service. However, that hasn't been finalised yet, and when we complete the change impact assessment, we'll get more clarity on that.
Where will health promotion and improvement sit in the new structure?
So we expect health promotion and improvement to be delivered as part of a CHA, nearest the patient as possible. We are doing some work in preparation for the health and wellbeing work stream with the heads of service for health and wellbeing in mapping out both the strategic and operational services that they provide. And once they do that, that will inform the work stream with public health to determine exactly how the services will be structured as we move forward.
Okay, and another one on that, where will primary care psychology sit and who will they report into?
So again, psychology services are delivered in a CHA, and the reporting relationship of the psychology managers will have to be looked at and hasn't been finalised as yet. Okay.
And just relating to the earlier question on ICPOP, Michelle has pointed out that ICPOP are not officially part of a national clinical programme. The next question then is that will each network of care have a service user rep and or family carer rep? You're on mute, Pat.
Yes, sir. We'll have some structured interface with service users, and even on our implementation team, we have 2 service user representatives on our implementation team.
Will community adult mental health and CAM services remap to the CHN-CHA geography?
I think that's the...
Oh yeah,
Sorry, go on, Mary.
Oh, so we expect a network of care with mental health to be stood up, and they will be looking at how the adult mental health services and the sectors within the adult mental health services could be aligned to the CHAs. The CAM service currently, we're not going to change the delivery of the CAM service at the moment, but again, as a network of care develops, this may change.
Okay. And Tony, will temporary contracts be extended longer than 3 months, or will this stay as is?
So we don't have a policy of issuing 3-month temporary contracts, and in the current in the current implementation phase, it's not about a 3-month contract. In fact, it's likely that we would be extending people out for 6 months, but it's very difficult to say because individual circumstances may be slightly different in each for each individual. So what I would say is, in general, though, what we're doing is we're extending people that are on temporary contracts in heads of service role and general manager roles out to the end of the implementation period, which, as I say, is about 6 months. But difficult to generalise.
And has consideration been given to how difficult it is to separate clinical and operational management for safe clinical service delivery? This has been an ongoing challenge for management teams in the network model, even with the best attempts at collaboration.
Yeah, so I might have a go at that one. And apologies, Kieran, now if I don't hit the nail on the head on this one. I suppose I'm leaning very much on my own experience on the networks of care at the hospital group level. Now, I know that's not the same as everybody's experience, but I do think it's relevant. And I would have had significant concerns when we started out on that journey about, are we, how are we going to get general management and clinical management to work together? How are we going to make sure that the lines aren't blurred and that people know where their responsibility starts and where it finishes, and so on? And actually, what we have found is that we found over a 6-year period at this stage is that that those types of concerns never really materialised, and that very quickly people came to understand the value that came with the networks of care, particularly around quality and patient safety, setting the strategy, setting the direction of travel, and equally that there was an appreciation of the value and the strength of the operational management on each site. And so through just working together, we found our way. I'm talking about networks of care, Pat. I know you just had to step up there for a second, but the concerns that might have been there at the start never materialized, and my expectation is that we would have the same experience this time.
And Tony, just in relation to the community healthcare networks and the division of the operational and clinical governance that was there, we are taking the learning from that, in particular in relation to our engagement around the health and social care professionals, and we'll be taking the learning from that as we move forward.
And I think just to re-emphasize what Tony said, I think our biggest concern when we rolled out the hospital-based MCANs, which are networks of care, was that there could be, and that was the biggest concern from the hospital management, is that there could be conflict and confusion about roles and responsibilities, authority. And I think a number of years into it now at this stage, I don't think that has not arisen, and that it is very much a supportive and a kind of a collective leadership to bring the strengths of the clinical leadership in the relevant discipline to support the hospital and the operational management structures.
Okay. A comment here. It is my understanding that only the GMs and heads of service from the community received letters of redeployment last week. Should we read into this that the acute sector does not require any reform?
So I think that's probably true. So just for everybody else that's on the call, we did write out to people last week that we know that their roles are going to be impacted by the current proposed changes. So they were heads of service and general managers on the community side for sure. There isn't as significant an impact on hospital managers. That's the truth. There isn't in what's currently proposed. There is some change for sure. For example, all hospital managers have changed their reporting relationship, and the Safe Hospital Group itself has been stood down. The group structures have all been are in the process of being dismantled as well as part of this. So there has been some significant change already on the hospital side, but I think other than that, I would agree that we have written out to the heads of service and general managers on the community side, because we see that in this phase, these are the people that are going to be most impacted by the proposed changes. I'm not sure, does the acute sector require reform? Probably require some, but I suppose going forward, what I would hope that less and less we'll be referring to acute sectors and community sectors, and we'll be talking about the health sector and what we're doing together to try and deliver care.
Where does immunisations sit within this new structure, both primary childhood immunisations and delivery of school immunisations?
So it's not envisaged that they will change from being delivered in the current structures that they're delivered in. They're delivered by our teams within the CHAs or by GPs. There is then the wider vaccination programme that covers a number of CHAs. And again, in the change impacts assessment piece that we're going to be doing under primary care, we'll be identifying that and see where's the best place for it to sit.
Is there a danger that there will be a lot of reporting into different structures and managers, for example, a CDNT to the GM of a CHA and to a disability head of service and so on, similarly with other categories of staff?
Yeah, I definitely understand where that question comes from, and I think what we'll see in the reality is that the reporting lines will be very, very clear, but it will be expected that people will be working with a number of others. So in trying to coordinate, for example, the disability services across the region, that will require a kind of a reporting with at a number of different working with at a number of different levels, but a very clear line for reporting to. And the basic reporting structure, runs through the through the IHAs in all cases.
Will rehab units remain under older person service and management structures?
So it's probably the simplest way for me to describe this would be to say there won't be an older person service, as Mary described earlier on. We're moving away from the care divisions that describe purely older person services as they're currently set up, or mental health services as they're currently set up, or primary care services as they're currently set up. So the structure will be under the IHAs. That said, we will have networks of care that will coordinate the activity of, for example, older people's services across the region. We'll have a network of care for mental health and that, and they will be combined in that way, or they will be connected in that way. It's probably the best way to describe it.
Okay. Has the experience and learning from the implementation of the CHN model been considered, given the challenges and matters it presented, which still have not been resolved with regard to separation of operational and clinical governance and management structures?
Yeah, so we referenced this earlier in the previous question, and yes, we are taking that learning on board.
And will the existing MCANs transition into the new networks of care model? And will the current MCAN directors and teams stay in place, or how will the structures be reviewed to better reflect its new integrated remit?
Well, and that's one of the work streams that we have in place on that Gantt chart, is how the existing networks, how we evolve them into regional networks rather than hospital-based networks, and that we will need to go and reappoint out to regional structures and redefine the roles of what were traditionally just hospital-based, but now we'll need to look at the relevant discipline across the entire continuum of care.
How will the allocation of administrative staff from grade 3 to grade 7 who currently work within the care group across the region be structured under the new framework?
So
yeah, go ahead, Mary, you go.
So we'll be looking at this as part of the change impact assessment, and we'll be mapping out, all of the staff that sit within care groups. Once it's done within care groups, we'll also be doing a change impact assessment on individuals and their roles and responsibilities, and that will come after the HR processes are complete. Sorry, Tony, you may wish to add to that.
The only thing I'd add to that, Mary, is that I think it's reasonable that for many people working within the service, particularly at lower grades, that they won't see any significant impact on their day-to-day working lives. As you move up the grades, and certainly at grade 6s and grade 7s, where the potential is that they may be providing or involved in the provision of services that cross CHAs, and there may be some changes for those people, but again, as Mary said, we worked that through. But for lots of people, they won't see a significant change in their day-to-day working lives.
Okay. And Pat, how can we learn more about the networks of care and how they will interact with the CHNs and CHAs, given that in community we have limited experience of working with them thus far?
I think Ebert said that's part of, we're still at the early implementation phase of defining the role of the networks that are more community-based, how they will interface. And I think there'll be much more discussion and engagement about the details and how that, but while it is in theory, very different, it is a collaborative way of working. And I think we've seen very much the gains and benefits from it in the acute hospital side. So I would hope that in the community side it would be of similarly of benefit and gain to the service providers.
Is it known yet where the HSE mobile vaccination service will be located once health and wellbeing is absorbed?
No, so this references the vaccination service that currently is delivered across, say, the West region and the Northwest region. So that hasn't been fully decided yet.
In a predominantly female workforce, how can staff be expected to deliver safe services without replacement of maternity leave?
What I would say is that, first of all, we've no firm policy decision or anything like that we don't replace maternity leave. And the truth is that with every request for cover for leave that comes through, we consider it on its own merits, but also on our ability to meet the costs that may be associated with it, costs in terms of pay costs, but also in terms of additional headcount. So, and that's really all that we can do in this context. And we have replaced provided some maternity leave cover across services, and we try and do it on the basis that that if there are a number of people leaving from a unit or from a department or from a ward or whatever it to be, that we may provide some level of cover across that. What I would say, and it is important to bear in mind, I agree that the non-replacement of staff definitely has an impact on services, no question about that. And that said, though, we have increased the number of staff working across the breadth of our services quite significantly over the last number of years. And even in the last 12 months, again, we have recruited quite a significant number of additional staff. So. I appreciate the difficulty that arises particularly within small teams when there's a gap for whatever reason, whether it's maternity or for other reasons. But just to say that we do our best within the resources that are available to us to provide cover when we can.
Can you clarify how the CDNT services will receive clinical governance and insurance by HSCP managers as per Force's recommendation/instruction to recruit discipline managers for the service in isolation for a period of 2 years initially?
So I think Marie is on the call with us. She may wish to take that question.
Yeah, I'm here. Thank you, Mary. Ciara, so the posts have been agreed for 12 months initially. We have been actively engaging with Mary Dorn, who's the A&D for Workforce Disability Services, and we've agreed as late as last week that we'll be working with Mary very closely to see how the new posts will integrate appropriately into the new IHA structures and design that we've been talking through.
Will HSE Social Inclusion report directly into the head of service and remain as regional management posts below the head of service?
Go ahead, Mary. Yeah, go ahead.
No, I don't want you. I'll let you go ahead this time, Tony, if you want.
I was only going to say I don't think we've that decided yet. We have to work that one through, we just haven't that one decided yet.
Okay. Where will counselling in primary care and national counselling service sit?
So again, the National Counselling Service currently sits under the governance of mental health. That will remain as is. And it's delivered out in our primary care centres, in our CHAs. And again, that will remain as it is. I think it's important to note that some structures won't change immediately. It'll be very much on a phased basis as we work through the outliers, and perhaps the National Counselling Service will be one of those that we'd look at a later date.
Okay. Where programmes include Section 39 SLAs for areas which are now to be divided into separate IHAs, how will that be managed?
Yeah, so it's a tricky one, and I think we're coming very, very close now to where we actually just have to nail the answer in relation to this. So even within our own region, we have a number of service providers under Section 38 and 39s that are stretching across a couple of IHAs. What we will try to do is put a system in place such that the primary interaction, the primary relationship is managed with one IHA manager, as opposed to an organisation having to work with two separate, or God forbid, even three separate IHA managers. That wouldn't make sense either from an IHA manager perspective or indeed from the service side. So we have to work that through and just nail that down. I mean, it's very simple and very straightforward where a provider is working just within one IHA, but there are lots of examples where they're stretching across not just a region, but also outside a region and into other areas. So I mean, we're all in favour of taking a sensible approach to this, where there's one primary leader in respect to that relationship, and then others feeding off it.
Have you considered where the community support team will sit?
And no, that hasn't been fully bottomed out as yet.
Okay. Can you please say a little more about the skills mapping process? How will this take place, and is it via management or HR?
So, well, I suppose HR or management, we're all management in that context. But I think probably the more accurate answer to this question is that how posts and roles are going to be filled, that'll be the process of an engagement between ourselves and the relevant unions. And I would expect that engagement to be taking place before the end of March, and that we'd have clarity then on an agreed process through which roles will be filled, and we'll progress with that in early April. Some of that may be about skills mapping, some of it may be about posts being advertised and people having to compete for them, and so on. We just have to work it through. The first step is to put a proposal to the relevant unions and to get agreement with them on how we progress that.
Will NRS continue to lead out in recruitment, or will there be a shift to regional recruitment?
Maria, I'm going to call you in on this one.
Yeah, so there will, I suppose, in the context of the roles that we've been talking about here, it has been agreed that NRS will be running the recruitment for those, but in a broader context, the region is very keen to recruit to its own regional workforce, and there has been a lot of engagement with NRS over the last number of months, but the objective is to have responsibility for recruiting our own workforce within the region.
How were GM's head of service personnel identified to receive the communication via telephone, email or letter, re their reassignment or redeployment?
I'm not 100% sure on this. Maria or Mary might have.
Yeah, Maria, let Maria come in there.
Yep, so the communication, I think, Bernie, that you're referring to there is just in, and was referenced earlier on. So this was to both temporary staff who we communicated with in terms of the extension of their contracts, Bernie, and then also to permanent staff. So those are staff across our region, including any impacted staff in Cavan.
Where will the public analysis lab, oh my goodness, currently in CHO2 sit in the new structure?
So the Public Analyst Lab will be assigned under one IHA manager.
Is there perhaps an email address or contact that employees in the region can seek information about the process relating to central services?
I'm not sure what's understood by central services. In my head, when I think of central services, I'm thinking about central HSE, as in Dr. Stevens and people largely based in Dublin. So I'm not sure about that question. If Emma wants to maybe give us a little bit more detail to work on there, we could.
Yeah, I'll come back to it, Emma, if you want to add to that. How are we to continue to deliver services in rural community areas where there are very small numbers of clinicians, single digits? For example, podiatry, radiology, where posts were unfilled in December 2023.
Yeah, again, I don't have the specifics, but I certainly take the point. Posts that were impacted by the pay number strategy, particularly where there were small teams, it's very difficult for us to regroup on that front. And I don't have good news this evening on that either. You know, we are continuing to work within the pay number strategy. We can look to see if there are possibilities in the upcoming service planning process for 2026, but again, I don't think there won't be significant numbers of opportunities to within that. There may be some, but not very significant.
Okay, I'm just going to jump to Emma because she came back in just to clarify that she was talking about staff that report nationally, for example, staff in HR shared services.
In HR. Oh, okay. So there are, there are staff that are working physically located within our region, but they're part of maybe national HR, or there's some people that are part of national finance, national procurement, and so on. There is a process through which the operating model for HR is currently being developed and finalised. I don't think, I mean, it hasn't been signed off by the REOs yet. I know that I've seen a draft of it, but I think it has a bit of work to go yet before it's finalised, and then it'll be clear for those staff that are working within the shared services where they're going to sit. Have I represented that? Do you think okay, Maria? Does that sound about right to you?
Yeah, absolutely. Yeah.
Okay. Tony, back to the piece on the maternity leave cover. Can you give an indication about the percentage of maternity leave covers that you are signing off on?
It's very difficult to say. I mean, I'd like to have a look back and see what kind of numbers. Might get everyone to go on mute. That's okay. But again, to answer the question honestly, I would say that that we are providing some level of cover. It's probably less than half of all applications that come through.
Okay. Will the identification and mapping of current structural and operational differences between CHO1 and CHO2 areas be a key focus of the change impact assessment?
Yeah, so the change impact assessment will first focus on care groups. So the biggest difference in the care groups will be between disability in the former CHO1 and CHO2, and that certainly will be identified as we do the change impact assessment. But it is across care group initially, so we expect all those differences to be identified at that stage.
Okay. And the final question we have at the moment is the new structure to be discussed with Forsa in mid-March?
Yes, but it has already been discussed with them. So we had a meeting with Forsa not last week, but the week before last, and I outlined actually in very similar detail what Mary outlined for you today in terms of the proposal, and that was just in respect of the West and the Northwest, and obviously the engagement with the Forsa is in relation to all 6 regions. So the next formal step in that is that that a formal proposal has to be put to them, which will describe what the model will look like and also how posts will be filled. I've already, as I say, given them an outline of what's proposed for the West and the Northwest, but that'll be done that week, the 3rd week of March.
Okay. And somebody just wondering about the comment earlier that admin staff at grade 6 level upwards may be impacted by role changes. Wanted to know, did they pick that up right?
Yeah, I suppose if you look at the way we deliver services currently, it's per care group, and some people may be assigned to older people, to mental health or to disability. As we move away from care group, that may impact on some individuals more than others. But again, we have to work that through.
Okay. And just a follow on in relation to the mapping of the current structural and operational differences, Orla's just come back to say it'll also be relevant outside of the care groups.
Absolutely, but I suppose we have to start somewhere, so we're going to start with the care groups, and then anything that falls outside of that we will also be mapping.
Okay. And will all HSCP managers be informed and invited to discussions, or just a representative group?
That initial meeting at the HSCPs, will be inviting all the managers.
Thank you, folks. So it was a bit of a fastest buzzer round, but I think you got through a lot there. If anyone has any further questions that they want to put in, now is your opportunity. This has been recorded and we will be sharing it around with all staff. And I just want to thank you all for your time, for all staff for attending, and for our question takers for going through so much. We do have a last minute one just to hit the gates. Where will nursing home support staff sit in the new structure?
So is that the CST team? Is that similar to, just so that I have it correct, the nursing home support staff that was referred to earlier? Fair deal. Pardon me, fair deal. Okay, so again, we have to work that out in relation to fair deal and other national schemes where they sit within the new structures, because they do go across a number of IHAs.
Okay, and just a few more. We'll try and get a few in just before we go. Do we know where occupational health services will lie?
Not just yet. It's part of the operational model for HR that's currently being finalised, and it's not finished yet, so it isn't. It will all be ironed out over the course of 6 months.
Okay. And currently the 9 CDNMs meet with the GM for children's disability monthly for operational management and planning, which is really important and valuable. How is the governance structure for children's disability envisaged, as the 15 CDNMs will be reporting to 15 different GMs, in my understanding?
Yeah, so I suppose that there are advantages and disadvantages to the care group structure, but and one of the advantages is that it helps to bring kind of cohesion and kind of critical mass across the whole job, across the whole region. So that's the advantage of the care group, and I think that's widely understood. We are moving away though from the care group structure, and so we are losing some of that to some extent. What we're gaining though is that disability becomes more embedded within its own CHAs and within its own community, and becomes part of that structure. And in time, I think that's consistent with Sláinte and in time it will hopefully build for a better health service. However, we absolutely do need to coordinate our disability, and indeed we do need to coordinate other services across the region as well. So there will be a regional post which will lead out on disability services, and will help with that coordination for sure. All of the IHA managers are part of a regional management team that must function and work together, so there'll be coordination at that level as well, and there'll be coordination of disability services at national level too. So yeah, I mean, I think it's a good question in the sense of, as we move to a new structure, how do we ensure that we still achieve a type of cohesion that's good for the service, good for people who use and depend on our services, you know. So we'll just keep a close eye on that.
Okay, thank you all very much. I think we've come to the end of all questions. And we are just a few minutes left in the time that we had allotted. So, Tony, if you want to wrap up.
Yeah, just a very quick comment for myself. First of all, to say thanks. I know that people are thanking us for doing the presentation, but I suppose I'm grateful to people turning up, and there was a huge number of people that turned up today with questions. And it's only through engaging in this way that I suppose that people get a better sense of what actually is happening, what is proposed, what are we trying to achieve, what are the pros and cons of it, and through that process then making it better. I do think that it is important that we retain the drive and the momentum for this change within ourselves. You know, it is something that will should be meaningful to the people that we're serving within the region, and therefore it's something that we should continue to steer and grab a hold of and to push forward, as we are currently and doing that for sure. I definitely think that we're coming to a point where there is significant change coming across the service, which will be good in the longer term, but it does impact on people, and so we do need to stay connected up over the next while as we're implementing these changes. As you know, some of the questions that myself and Mary and Pat didn't have answers for this evening, as some of those issues become clearer, we need to stay connected up and in contact again, so that people feel that they're reasonably well informed as we progress through the process. I would remind everybody, just as Pat did earlier on, that while today is the 3rd of March, and so the interim phase comes to an end today, we are only commencing the implementation phase, and so for people that had a reporting relationship last Friday or were involved in the delivery of care in a particular way last Friday, that hasn't changed today, and it won't change again until we've been talking to people and working it through with people, you know. So we all just keep going as we are, delivering services every day, the same as we always do, and then we'll continue to try and develop and implement these changes over the next 6 months.
And unfortunately, I'm going to get one more in because it came in, and we'll get all the questions answered. Will existing recruitment panels stay in place?
And the short answer to that is I don't know, because I suspect that for some people and for some of those panels, that would be something that we would have to engage with Forsa about as well, and with other unions possibly as well. So we'll just work that through as part of the process. I'm certain it's an issue that will arise in that context.
Thank you very much, everyone. Okay, we'll end it there. Thanks again, and we will be doing this again shortly. So you can take a breath first, but not
Thank
too
you.
much.
Thank you.
Thanks, Will. Thanks.